18 and trisomy 13. After that, maternal blood testing, the triple screen is important. The abnormal results of the AFP, beta-HCG, and estriol would suggest a chromosomal abnormality, and then on ultrasound we'll see multiple anomalies and may be associated with IUGR, and then the confirmation would be done by the chromosomal analysis, which includes chorionic villus sampling, amniocentesis, and fetal blood sampling. I'd be going for the ultrasound findings, but just a quick revision of what is trisomy. You have an extra chromosome available in trisomy, and you have one chromosome absent in monosomy. In triploidy, you will have 3 sets of the chromosomes. In the first trimester, you have a nuchal translucency is an important sign. It's this black space at the back of the neck. It should be less than 3 millimeters. If it is more than 3 millimeters, then that is abnormal during 10 to 14 weeks and has a strong association with trisomy 21, but may also be seen in trisomy 18 and monosomy X. But you also see the nuchal translucency in other conditions like cystic hygroma or hydrops fetalis or omphalocele, and some genetic syndromes, and the things are being added to this list every day. But once you see the nuchal translucency is abnormal, then about 30% of such patients would have a chromosomal abnormalities. There are other signs in the first trimester like abnormal yolk sac and amniotic that is too tight or a shapeless embryo, but that has been talked by Dr. Yashodhara yesterday. I'll be going to the second trimester findings. That is how I would approach, that is more practical approach towards the diagnosis of the chromosomal abnormalities when I am put for this anomaly scan that I'm doing in the second trimester. I'll be starting with the head, and if the BPD and the occipitofrontal diameter are both small, then I would suspect microcephaly. But it's important that you look at the head in the sagittal view, and normally the calvarium should be going like this. If it is small compared to the size of the face, then that is quite suggestive of microcephaly. Microcephaly is not a typical indicator of a particular chromosomal abnormality, but it would suggest chromosomal abnormality in about 20% of the cases. Another next thing would be the shape of the head. If the shape of the head appears quite broad, that is the BPD is broad compared to the occipitofrontal diameter, then it is brachycephaly. It is measured by the sphalic index, that is ratio of the BPD to the occipitofrontal diameter, and if the sphalic index is more than 85%, it would suggest brachycephaly. Brachycephaly can be a normal variant, but it also has association with 21, trisomy 21. Another abnormal shape of the head could be the strawberry head, in which you have a flattened occipital area and a narrow frontal area, giving it the appearance of strawberry sign. It is usually also associated with some brain abnormalities and has an association with trisomy 18. Now, after looking at the size and shape of the head, I'll go into the brain, and if there is mild ventriculomegaly, it may be associated with chromosomal abnormalities in about 15% of the cases, especially when there are other associated fetal anomalies. But if the ventricles are markedly dilated, then it is hydrocephalus. Now, within the ventricle, I'll be looking for the presence of choroid plexus cyst. If the choroid plexus cyst is the only finding, there are no associated abnormalities, then I would follow it up, but going for amniocentesis is not really worth, because when the choroid plexus cyst is just an isolated finding, then 1 out of 400 fetuses with choroid plexus cyst are likely to have trisomy 18. But if you have an associated findings, other abnormalities, then it is more likely to represent trisomy 18. So the risk of losing fetus by amniocentesis is also there, which is more than that. So it is better that we follow up such cysts in which there are no associated abnormalities. Same is true about the agenesis of the corpus callosum, that it is an important marker when it is associated with other fetal abnormalities. You can see in agenesis of corpus callosum there is a teardrop-shaped lateral ventricle, and the third ventricle should be at a lower level, but it is at the level where there is lateral ventricle and it is also dilated. You can also confirm that in the coronal view that these are the anterior horns of the lateral ventricles, and the third ventricle is located at that level. It should be down over here. So that has an association with trisomy 13 and 18. Then is the Dandy-Walker malformation. That is a triangular cystic area in the posterior fossa that may or may not be communicating with the fourth ventricle, and then we have this Dandy-Walker malformation and this variant, which is just an enlarged cisterna magna, that also has an association with trisomy 13 and 18, especially when associated with other abnormalities. Within the brain, sometimes a rare finding is a holoprosencephaly, in which there is failure of cleavage of the ventricular system, so that there is a single large monoventricle that has an association with trisomy 13 and 18. Now, after looking at the head, I'll come down to the level of the eyes, and I would look at the orbits. If the orbits are too close to each other, that is hypotelorism, then it may have association with trisomy 13. And I'd take the binocular distance and the interocular distance, and if this interocular distance is less than 1/3 of this binocular distance, then I would suspect a hypotelorism. Now, after that, I'll come down to the level of the neck, of the nose, and if there is an abnormal development of the nose, which looks like an appendage, which comes down like this, and there is a single nostril in the center, that may have an association with trisomy 13 and 18. From nose, I'll come down to the lips, and if I see a cleft lip, like you see it over here in the axial view, where you have nose and the upper lip and the lower lip, and there you see this cleft, that may have association with trisomy 13 and 18. From there, I'll come down to the chin. If there is hypoplasia of the mandible, then the chin appears very small in size, which is micrognathia, and that has an association with trisomy 13, 18, and triploidy. After that, I'll come to the neck, and in the neck, this is the thickening of the nuchal fold, which should be less than 6 millimeters in the 15th to 22 weeks, and if it is more than that, then it has an association with trisomy 21. There you have this pleural effusion. I would look for the other signs of the hydrops fetalis, because if it is non-immune hydrops fetalis, it may have an association with chromosomal abnormalities. You can see other signs of the hydrops fetalis, that is a marked scalp edema and marked skin edema. You have ascites, pleural effusions, pericardial effusions. Diaphragmatic hernia may have an association with trisomy 18, in which you see that the heart is pushed to the right side, and on the left side the space is occupied by the stomach, which is lying at the level of the heart, and there is marked polyhydramnios. At the same level, that is at the level of the stomach, I'd look for the presence of the stomach. If you do not see a stomach, or if you see an underfilled stomach, it may have an association with trisomy 18. Usually it is an underfilled stomach. It is rare to see a stomach which is absent, because usually you have from 95% of such cases have an associated tracheoesophageal atresia, tracheoesophageal fistula, through which the food would enter into the stomach. Now, at the level of the stomach, I will be looking for the double bubble sign, the stomach and the duodenum because of the duodenar atresia that has an association with trisomy 21. Then I come down to the level of the bowel. If I see an obstructed bowel that has association with 21, and if I see echogenic bowel that also has association with the trisomy 21. And at the level of the insertion of the cord, if I see a defect in the abdominal wall through which the liver comes out and is surrounded by the membrane, then it is omphalocele, and that has association with trisomy 13 and 18. From there, I'll go to the back and look for the kidneys. If there is mild hydronephrosis, it may be associated with trisomy 21, and if there is moderate to severe hydronephrosis, then it may be associated with trisomy 13 and 18. If I see a multicystic dysplastic kidney, then it may be associated with trisomy 13 and 18. A large obstructed bladder may also be seen in case of trisomy 13 and 18. And from there I'll come down to the level of the genitalia, and if I see the ambiguous genitalia that may have an association with triploidy and trisomy 18. I'm sorry, it is not 21, it is triploidy and trisomy 18. And other sex chromosomal abnormalities may also be associated with ambiguous genitalia. From there I'll come down to the legs, and if I see that the femur is short, femur should not be very short, that would suggest a skeletal dysplasia, but it would be like 90% of the expected size of the femur, then it may have association with 21. After that I'll come down to the foot, and if I see that in the side view of the leg and the foot, I do not see the side view of the foot, but I see the sole of the foot, which I should not be seeing in this sort of view, then that suggests club foot, which has an association with trisomy 13 and trisomy 18. Another finding could be the rocker bottom foot, in which the sole, instead of being concave, it is convex because of the malposition of the talus and the calcaneus bones, which has association with trisomy 18. Then overall size of the fetus is important. If there is marked IUGR, it should be associated with triploidy. Triploidy is the main finding which is missing over here, but it may also be associated with trisomy 13 and